Hello, my name is Gospel Okoye. Welcome to my Nursing 641 Psychopharmacology case presentation on Effexor. Effexor is the trade name of venlafaxine, an antidepressant in the serotonin norepinephrine reuptake inhibitor SNRI class, used to treat major depressive disorder and anxiety disorders. Effexor works by inhibiting serotonin and norepinephrine reuptake, two neurotransmitters involved in mood regulation and stress response. By increasing the availability of these neurotransmitters in the synaptic cleft, Effexor can enhance their effects and reduce the symptoms of depression and anxiety. Effexor is extensively metabolized in the liver by the cytochrome P450 enzymes CYP2D6 and CYP3A4 to its active metabolite, O-desmethyl venlafaxine ODV, which has similar pharmacological activity as venlafaxine. The kidneys primarily eliminate both venlafaxine and ODV. Effexor belongs to drug classes of antidepressant, mood stabilizer, and SNRI. Effexor is used to treat depression, generalized anxiety disorder, social anxiety disorder, social phobia, panic disorder, post-traumatic stress disorder, and premenstrual dysphoric disorder. Side effects of venlafaxine include nausea, headache, insomnia, drowsiness, dry mouth, sweating, constipation, sexual dysfunction, increased blood pressure. Life-threatening side effects include seizures, hyponatremia, bleeding disorder, and also discontinuation syndrome. Effexor is contraindicated in uncontrollable angle closure glaucoma, proving allergy to Effexor, and taking MAOI. Benefits of Effexor. Effexor works to regulate both serotonin and norepinephrine levels in the brain. It is more effective in treating symptoms of depression than SSRIs. Case study number 1, identifying data. Summary. JK is a 35-year-old Hispanic female referred to me by her primary doctor for evaluation and treatment of depression and anxiety. She works as a cashier in a supermarket. She has no children and has never been married. She has a history of childhood abuse and neglect by alcoholic patients who are both diseased. Background, source and reliability. The history obtained from the patient and primary doctor are reliable. Chief complaint: I feel depressed and anxious all the time. I don't enjoy anything anymore. History of present illness. She recently lost her job as a secretary in a law firm, has difficulty finding another good paying job, settled for a low paying job, felt trapped in dead-end job with no prospects of advancement, avoided social situations because she felt insecure and anxious about being judged or rejected by others. Panic. She panics when facing stressful situations. She has low mood, anhedonia, insomnia, fatigue, poor concentration, and irritability. She has no current medications and no reported allergies. Past psychiatric history. Reported episodes of depression since her adolescence, but never sought professional help until now. She has been previously diagnosed with MDD and GAD and treated with various antidepressants that she stated did not help her or cause intolerable side effects. Past psychiatric medications include fluoxetine 20 milligrams daily, discontinued due to headache. Medical history, none. Family history, both parents were alcoholics and deceased. Social history, denies alcohol or drug use. Case study number 1 continues. Diagnostic test, laboratory test, CBC, CMP, TSH, EKG, and all are all within normal limits. Hamilton Depression Rating Scales and Hamilton Anxiety Rating Scales indicated severe depression and anxiety respectively. Mental status exam, sad, tearful, poor eye contact and minimal facial expression, slow, monotonous speech, feeling worthless, hopeless, and helpless, denies any hallucination or suicidal ideation. Assets and liabilities, has fair insight and judgment of disease. Memory, attention, and concentration are mildly impaired. Case formulation, differential diagnosis, major depressive disorder, MDD, generalized anxiety disorder, and post-traumatic stress disorder, American dysmetric disorder. Diagnosis, psychiatric, major depressive disorder, MDD, ICD-10 code F32.2, general anxiety disorder, ICD-10 code F41.1. Treatment, pharmacology, Effexor, XR, 75 milligrams once daily, times 2 to 4 weeks, then 150 milligrams depending on how she responds and tolerates it. Monitor blood pressure. Non-pharmacological interventions refer to qualified psychotherapists for CPT, cognitive behavioral therapy, and social skill training. Regular exercise and balanced diet. Teach stress reduction techniques such as mindfulness, meditation, and progressive muscle relaxation. Patient and family education. Educate patients for the need to follow up and also medication adherence, possible side effects, and how to manage it, and when to report to the provider. Monitor blood pressure. Do not stop taking medication abruptly to avoid discontinuation syndrome. Refer to an ophthalmologist to check for narrow angle glaucoma. Case discussion. JK has a history of depression and anxiety, previously treated with SSRIs, not effective, complaints of side effects. Effexor is a good choice for JK's treatment. Target symptoms: social phobia, low mood, psychotic episode, panic disorder. Potential barriers: language barrier, cultural barriers, or mistrust of the healthcare system. Challenges with medication adherence. Cultural considerations. Impact on her views on mental health treatment and medication. Adopt treatment strategies to accommodate her cultural beliefs. Summary: Mr. X is a 45-year-old. Case number 2. Mr. X is a 45-year-old African-American male referred to the clinic by his primary care physician for evaluation of depressive symptoms. Sources and reliability. History was obtained from the patient and his PMD, and they are reliable. Chief complaint: I feel so sad, hopeless, worthless, and guilty for some time now. History of present illness. Patient feels sad, hopeless, and worthless, difficulty sleeping at night, poor appetite with 10 pounds weight loss in 1 month, low self-esteem and negative thoughts about self, works as an accountant in a large firm but is unsatisfied with his job, suicidal ideation, but has no specific plan or intent. Complaint with medications previously treated with Prozac and Zoloft, but none worked for him or caused intolerable side effects. Current medications: Novax 5 milligrams daily for hypertension, past psychiatric history. First diagnosed with depression at the age of 32, he started on antidepressants, which he later stopped taking. Past psychiatric medications: Prozac 20 milligrams daily, Zoloft 50 milligrams daily. Medical history of hypertension, no allergies. Is a college graduate, no history of substance abuse. Both parents were deceased when the patient was 21 years old. Relationship with siblings are estranged. No significant family history otherwise. Diagnostic tests: CBC, CMP, EKG, all within normal limits except for total cholesterol of 240 mg/dl. Mental exam, status exam: depressed mood, flat affect, poor eye contact, psychomotor, suicidal thoughts, no delusions or hallucinations, memories and orientation intact. Assets and liabilities: thought process is coherent, intact, well kept, receptive and participatory, pessimistic and ruminative. Physical findings: unremarkable except for mild hypertension and elevated cholesterol. Differential diagnosis: major depressive disorder. Diagnosis: psychiatric. Major depressive disorder, recurrent, severe without psychotic features. F33.2. Diagnosis: medical, essential hypertension, hypercholesteremia. Current treatment plan: Cymbalta at 30 milligrams daily times 1 week will advance 60 if tolerated. Monitor labs: CMP, ALT, CMP, CBC. Non-pharmacological treatment: refer to psychotherapists for CPT and social skill training. Stress reduction. Family education: educate on MDD/symptoms, medication side effects and management. Importance of medication adherence. Case discussion: Mr. X has a long history of untreated MDD. Previous treatment with other antipsychotics has failed. Hypertension, hypercholesteremia. Effexor is not appropriate choice for treatment. Effexor can increase blood pressure and cholesterol levels, worsening the patient's cardiovascular risk. Effexor can cause sexual dysfunctions and further impair patient's self-esteem and quality of life. Effexor can interact with the medications the patient may need to take, such as antihypertensives and statins. Target symptoms: apathy, loss of appetite, weight loss, irritability. Barriers: the patient might have low motivation or compliance due to hopelessness and pessimism. The patient might have difficulty trusting the psychotherapist or the clinician due to their negative self-image and interpersonal problems. The lesson learned. I learned the importance of taking a holistic approach to patient care, considering biological, psychological, social, and cultural factors that can impact a patient's mental health. I also learned the significance of evidence-based practice in psychopharmacology and the importance of regular monitoring and communication with patients to ensure the efficacy and safety of their treatment plan. Lastly, I learned the importance of tailoring treatment to the patient's needs and preferences, considering their medical history, previous treatment responses, and potential side effects. This is the end of my presentation. Thank you for listening to my presentation.